this. All right.
All right. Good afternoon, everyone. My name is Rahul Patel. I'm one of the endocrinologists here at Metro, and I'm going to be giving this lecture on inpatient diabetes management for the nuts and bolts series. So what you're going to get is the nuts and bolts of the inpatient diabetes. Can people in the back or up high hear me okay? Yes. Okay. So the objectives of the talk are a couple things. So one is to highlight the importance of glycemic control and targets for hospitalized patients. Another will be to review the recommendations on the diagnosis and monitoring of hyperglycemia during admissions. And then finally, we'll kind of discuss the approach to management of hyperglycemia for different inpatient settings. So why is glycemic control important in the hospital? Well, diabetic patients incur about 22% of all inpatient days. And about 30% of diabetic patients are admitted 2 or more times every year to the hospital. And we know that hyperglycemia also results in poor outcomes. There's data showing prolonged hospital stays, increased rate of infections, and more disability after discharge. And then some studies kind of show there may be an increase in mortality, but then there's some that say, well, maybe not, but so that's something else. But this is just a graph kind of showing data for all-cause hospitalizations per 1,000 person years there in the y-axis. And then basically they're plotting in that top line there, the diabetes that's poorly controlled, A1C above 7, and then the line below that, they have patients with diabetes with a A1C under 7, and then patients who don't have previous diagnoses of diabetes with various degrees of control. And basically, it's just to illustrate, especially in the adult and older adult population here, that patients with diabetes or worse glycemic control tend to be hospitalized more compared to patients who have better glycemic control. Some of the changes that go on when a patient is admitted, both metabolically, physiologically, the acute stress of a hospitalization from cortisol and other catecholamines can lead to lipolysis and muscle protein breakdown. And then you get these free fatty acids and amino acids that go to the liver. The liver then increases glucose output. And along with some of the various stresses and factors that you can see there on the left that go on during the hospitalization, this can all lead to hyperglycemia, which has various effects. So on the immune system, it can impair leukocyte function and phagocytosis, increasing the risk for wound and systemic infections. Hemodynamically, with hyperglycemia, you can have an osmotic diuresis, which can lead to volume depletion, dehydration, electrolyte loss, and tissue hypoperfusion. And then the effects of hyperglycemia on the tissues themselves include inflammation and oxidative stress, endothelial dysfunction, and mitochondrial injury. So all these factors can kind of contribute to the poorer outcomes that I mentioned in the last slide, sepsis, multi-organ failure, and death in some cases. So as far as testing goes for patients who are admitted into the hospital, the Endocrine Society recommends that all patients should have a lab blood glucose upon admission, and pretty much everyone gets this because everyone gets like a BMP or a comprehensive metabolic panel, so pretty much all patients get a blood sugar on admission. And then the American Diabetes Association and Endocrine Society both recommend checking an A1C on all patients with a history of diabetes or a blood sugar greater than 140 if one has not been done in the last 3 months. And then, so there's a few different societies, by the way, for that kind of have some guidelines or recommendations for diabetes and in the endocrine world. So we have Endocrine Society, American Diabetes Association, and the American Association of Clinical Endocrinologists, or ACE. So I'll be kind of mentioning, they all have each their own guidelines, so I kind of used all of them and kind of mixed them into the talk here. So I'll be mentioning the different societies and their guidelines throughout the talk. For non-diabetic patients, if their blood sugar is greater than 140, or if they're on corticosteroids or on enteral or parenteral nutrition, so IV nutrition or tube feeds, they should have the point-of-care blood glucose testing for 24 to 48 hours. And those who have a blood sugar above 140 are recommended to have ongoing testing and or treatment. Insulin therapy is recommended for patients who have persistent blood sugars above 180. And when we do treat patients, there are a couple goals depending on the acuity of the patient. So for patients who are not critically ill, the Endocrine Society recommends pre-meal sugar below 140 and a random blood sugar of under 180 as the goal. ADA recommends basically keeping the sugars within the range of 140 to 180. But for some patients who can achieve even better control than that without risking hypoglycemia, then a lower or more strict range would be appropriate. Although it's not really clear what that range would be. I think ADA said that, they kind of worded that 110 to 140 may be okay. So there's that. Patients who have a very limited life expectancy, very high risk of hypoglycemia, and they're very elderly, and so really you're just trying to avoid hypoglycemia at all costs, and then a looser target, even under 200, might be okay in those situations. For critically ill patients, the goal for the target is 140 to 180. Pretty much all the societies kind of agree on that. That's mostly based on the NICE sugar trial, which came out a few years back. And this was a large study that compared over 6,000 patients in the ICU setting who had been in the ICU for at least 3 days. And it basically stratified them to a target blood sugar of under 180 versus a target that was more strict in the 80 to 110 range. And the patients who had the looser control, who ended up being in the 140 to 180 range, they ended up having a lower 90-day mortality compared to the tighter control group. And they had less severe hypoglycemia episodes, which they defined as sugars under 40. So that was also a lot less in the looser control patients, as you can see there. So, and there was no difference in the days in the ICU or in the hospital either. So that's where the recommendation for critically ill patients, keeping them in the 140 to 180 range, has kind of been solidified from. For monitoring patients, basically monitoring, we recommend with the bedside a capillary point of care test of, your regular blood glucose monitor tests. These are preferred. Continuous glucose monitor systems, which are, a newer technology where a patient wears a sensor with a soft needle right under the skin, and it measures the subcutaneous tissue glucose continuously 24/7. These systems have not really been studied well enough yet to establish their efficacy and safety. So they're not right now anyway routinely recommended, but could be something in the future if that safety and efficacy is established, and if it's probably cost efficient, that's probably going to factor into that as well down the road. Basically, as far as monitoring for a patient who's eating, you want to check their sugars before meals and at bedtime. If the patient is NPO or on tube feeds or IV nutrition, then the recommendation is to check their blood glucose every 4 to 6 hours. As far as treatment for diabetes, pretty much all patients who are conscious anyway should get the diabetes education, diabetes self-management education. And then if they're eating, consistent carbohydrate diet is recommended for all these patients. Usually that ends up being 45 to 60 grams carb per meal. For critically ill patients, patients with DKA or HHS, we recommend IV insulin, and then for non-critically ill patients, typically basal bolus insulin is what's recommended. And so let's go over that. But first, so non-insulin therapies, so your oral hypoglycemic agents, metformin, sulfonylureas, DPP-4 inhibitors, GLP-1 agonists, all these things are usually discontinued upon admission, and an insulin regimen ends up being implemented. Metformin, you definitely don't want to use in acute kidney injury, decompensated heart failure, or decompensated cirrhosis. Basically, any situation where there may be intravascular volume depletion can increase the risk of lactic acidosis. So we discontinue the metformin in these patients. And that includes, for patients going to surgery, and their volume status can kind of shift during or after the operation. Or if they're getting IV contrast and their GFR is under 60, then it's recommended that the metformin be held for that. There is some active research and some pilot studies out that suggest that maybe using a basal insulin like Lantus and a DPP-4 inhibitor such as linagliptin or Tradjenta, or the other ones are like Januvia, which is sitagliptin. These can result in similar glycemic control as a basal bolus regimen, so that may be something that we might use more commonly going forward. For the other non-insulin therapies, especially the newer ones, again, safety and efficacy kind of still need to be established. So, for example, the SGLT2 inhibitors like canagliflozin or empagliflozin, which are Invokana and Jardiance, they can cause volume depletion, which may worsen renal function. And they increase the risk of yeast infections or UTI. So those may not really be appropriate for an inpatient hospital setting. And then GLP-1 agonists like liraglutide, Victoza, which are very effective in the outpatient setting, they slow gastric emptying and might cause nausea, constipation, and other GI side effects. So for a lot of patients who are admitted in the hospital when their PO status is kind of changing and their ability to tolerate food is changing, it may not be appropriate for them either. But the caveat to all of this, too, is that, if you have a patient who's very, very clinically kind of doing well, stable, eating regularly, then, we could consider potentially continuing their home oral hypoglycemics. So for non-critically ill patients, when they're NPO, we usually just give the basal insulin, which is typically Lantus, and then a sliding scale correction insulin every 4 to 6 hours with a bolus insulin, which usually refers to Humalog or Novolog. And then if they're eating, you give that basal insulin like Lantus, but then you also give a scheduled mealtime bolus dose of Humalog or Novolog. And then additionally, you give a sliding scale amount to correct for high blood sugars, and you only do that before meals. So you may check the sugar at bedtime, but we do not give a bolus dose of Humalog or Novolog at bedtime because there's a high risk of hypoglycemia then in the middle of the night. This is just a table looking at the pharmacokinetics of the different subcutaneous insulin preparations that we use. So the rapid-acting analogs, that refers to Humalog, Novolog. Basically, their onset is pretty quick, 5 to 15 minutes. They peak within an hour or two, and the duration is 4 to 6 hours, typically closer to 4 hours if you have a normal renal function. Our insulin, regular insulin, we don't use as often, but sometimes we do. And you can see it's a little slower onset, longer time to peak, and a little bit longer duration. Again, usually closer to 6 hours with normal renal function. For the long-acting insulins, there's NPH, which peaks 4 to 10 hours, and then usually we give it BID because it's close to a 12-hour duration. Glargine or Lantus is more of a 24-hour duration, so we give it once a day. Other insulins like Toujeo, Basaglar, and Tresiba are pretty similar, but we don't really use them here in the inpatient setting. And then Detamir, which is Levemir, we use sometimes. It is not as long of a duration typically as Lantus. So some patients are on this once a day, but many of them, because it's closer to an 18-hour maybe duration, they might need their Levemir dosed BID. And this can be important, especially in type 1 diabetics. If the Levemir is only being given once a day, it's not lasting the full 24 hours, then they could be subjected to several hours of basically having no insulin in their system, so to speak, and that can increase the risk of DKA. So if you're giving Levemir to type 1 diabetic, it's generally a good idea to use that as a BID. Okay. So for these non-critically ill patients, so like I said, we give them basal insulin, which is Lantus. And when you're evaluating the dose of Lantus that someone's on, kind of when they're already in the hospital, the Lantus should ideally keep the blood sugar stable while they're in the fasting state. And the way we evaluate this on a day-to-day basis is comparing the bedtime blood sugar to the next morning blood sugar. Okay, so if the blood sugar should generally be stable from the time of bedtime to the next morning. And if it is stable, then that indicates that your Lantus dose is probably appropriate. And if they were to continue in the fasting state and they were not eating during the day, then that same dose of Lantus would keep them stable during the day as well. So that's kind of how we evaluate for what the right dose of the basal insulin is. The bolus insulin, the Humalog and Novolog, remember, has two parts. So for a patient who's eating, you don't just give the sliding scale insulin. It's not going to appropriately cover them because, again, there's two parts to the bolus dose. One is that they need a scheduled mealtime dose to cover the rise in blood sugar that's going to happen after they consume carbohydrates. So, when you consume carbohydrates, there's a proportional rise, depending on how many carbohydrates you're eating, in your blood sugar. And so you need a certain amount of the Humalog just to cover that and keep you stable. So we usually evaluate this. We look at the blood sugar before one meal, and then look at the blood sugar before the next meal, and whatever amount of Humalog or Novolog kind of keeps them stable from one meal to the next is a good scheduled amount of Humalog or Novolog to give as your base amount for the meal. And then you can give a sliding scale amount of Humalog or Novolog on top of that, so you get extra of the bolus dose if the blood sugar is high. And the point there is to correct and bring down the high blood sugar so it comes back into the normal range by the next meal. So when a patient is admitted, if they're already on a basal bolus insulin and you're trying to decide, what to start them on, generally a good rule of thumb is you could do 70% of their home doses of Lantus and Humalog and start there, and then adjust it accordingly depending on how they're doing during their stay. If it's an insulin-naive patient, so this is a new start for them for insulin, you can, what we often do is calculate their total daily insulin requirement based on their body weight, which would be about half a unit per kilogram. And then we divide this half and half between the basal insulin and the bolus insulins. So, for example, if you have a patient who's about 80 kilograms and you're starting them on insulin for the first time, half of the 80 kilograms, so 0.5 units divided by the 80 kilograms, you'll get 40 units total daily requirement. And then you split this up 50-50, so you get 20 units of Lantus. And if they're eating, it could be 6 or 7 units of Humalog before each meal, breakfast, lunch, dinner. And then you give a sliding scale on top of that, such as like 2 units for every blood sugar of 50 points above 150, which is basically 2 units if they're 150 to 200, 4 if they're 200 to 250, and so on and so on. So these are some numbers that I made up, but it kind of reflects what we might do when we're evaluating a patient's glycemic control while they're in the hospital. So you can kind of see in the morning their blood sugar is 180, and they're on the 6 units scheduled before the meals. So they get 6 units plus 2 of the sliding scale. They get checked again at lunch. They're still at 180. They again get 6 plus plus the 2 of sliding scale. By dinner, their sugar has gone up to 220. So they get, again, their 6 units that's ordered plus 4 units of sliding scale this time. And then by bedtime, they're kind of stable at 220. Then they get their Lantus 20 units at night, and then the next morning they're still at 220. So looking at that, the Lantus, it kept them stable from bedtime to the next morning. So I would say, okay, that's a good dose of Lantus. Continue that at 20 units. If you look at the breakfast Humalog, so they had 6 plus 2, which was 8, and that 8 units kept them stable, even though they were high. It kept them stable from 180 to 180 at the next meal. So, okay, the new scheduled mealtime dose for breakfast should be 8 units because that kept them stable. And then you can look at the lunch. 8 units that he got total at lunch wasn't enough. So then we would increase the lunch even beyond 8 units, so we could try 10 units at lunch. And then you can see at dinner, he got 6 plus 4, which was 10, and that kept him stable. So then we would recommend, okay, 10 units for dinner as a scheduled dose to keep him stable for dinner. So then the new recommendations would be increasing the Humalog to 8, 10, and 10. In certain other special situations for patients who are admitted when they're receiving glucocorticoids, so prednisone, dexamethasone, hydrocortisone most commonly, this can really exacerbate the prandial glycemic excursion that happens. So when you eat carbohydrates and your blood sugar spikes up from the carbohydrates, this spike in blood sugar can be considerably more when you're on glucocorticoids. So in general, you want to increase the bolus by 50%, so it can be pretty significant. So if your Humalog was 10 units, you could increase it to 15 units, for example, if they're on steroids. For patients who don't have a previous history of diabetes, if they're on glucocorticoids, again, you monitor them for 24 to 48 hours. If their sugar is fine, if it's under 140, then you can stop monitoring after that. So for patient on tube feeds or IV nutrition, we basically recommend continuing their prior basal, so the prior Lantus amount, if it was appropriate, hopefully. And then, or you can calculate it based on their weight and come up with the total daily dose of insulin like we did in the previous example and figure out what their Lantus would be from that. Then you would give a scheduled bolus every 4 hours if you're giving Humalog or Novolog, or every 6 hours if you're giving regular insulin. Again, going back to that 80-kilogram patient, you would calculate 20 units of Lantus, and then another 20 units kind of divvied up with your scheduled bolus every 4 hours of Humalog. So it'd be 3 or 4 units every 4 hours of Humalog, plus the sliding scale on top of that. Then if a patient, because this happens often, their tube feeds are held, you would continue, or the IV nutrition is held, you would continue the basal amount, the Lantus, which again, if it's appropriate, it should keep them stable even when they're not getting any nutrition. And then you should hold so you hold the scheduled bolus amount then because they're no longer getting that nutrition, but you still give the sliding scale amount every 4 hours or every 6 hours. For IV nutrition, you could also alternatively add regular insulin to the TPN bag, the IV solution. One recommendation from the ADA was you could try starting at 1 unit for every 10 grams of carbs in the bag, and then have a sliding scale every 4 to 6 hours along with that. Patients who are going to be undergoing surgery, so they're NPO after midnight for surgery, we typically say give 60 to 80% of the basal insulin, the Lantus, the night before, and then hold any non-insulin therapies the day of the surgery. And you can still give them just the sliding scale of Humalog or Novolog or regular, whatever it is, every 4 to 6 hours while they're NPO. If a patient comes in on an insulin pump, usually we just recommend letting the patient to just keep using the insulin pump as long as it's functioning appropriately. The patient or the nurse can check the blood sugars 4 times a day. The patient will then take that blood sugar, calculate the carbs they are eating or have eaten, and put that into the pump, and then the pump will give them their bolus amount after making the calculations. And then we can, of course, adjust the pump settings so that basal rate can be lowered or increased if needed, or the bolus amount can be adjusted as well if needed. For critically ill patients, again, the goal is 140 to 180 for their blood sugars, and continuous IV insulin is typically preferred if they're critically ill. For patients with DKA or HHS, we usually say start with the IV regular insulin, usually with a bolus of 0.1 units per kilogram, then an infusion at 0.1 units per kilogram per hour that you can titrate, usually per protocol. Most hospitals have their own IV insulin protocols. If they don't, then one thing you could do if you're stuck to kind of changing the order every hour or something, if you don't have a protocol, if the blood sugar isn't decreasing by 50 or 70 in the first hour, you can double the dose of the rate. And then once the blood sugar is 200, you can decrease the rate, as you can see there. And then just remember, too, outside of insulin for patients with DKA and HHS, you always want to be pretty aggressive in repleting their fluid losses, which can average 3 to 6 liters in DKA and even more, 8 to 10 liters in HHS. So you may need to be pretty aggressive, 1 liter an hour, something like that, in the first few hours, and then reassessing their volume status and changing them to maintenance IV fluid, which can still be pretty intense compared to the normal maintenance IV fluid that we do. When the blood sugar is around 200, then you can add D5 to their IV fluid. If they have DKA, or even 250 to 300 if it's HHS, then you can add the D5 then. And then when a patient is eating and their gap is closed, if it's DKA, or if their mentation, their altered mental status has improved, if this is HHS, then you can discontinue the insulin drip and transition them to a basal bolus subcutaneous insulin regimen. The important thing that you want to remember when you are doing that transition too is that you want to stop the insulin for about 2 hours after giving the basal insulin dose. So remember, it takes a couple hours for the Lantus to kind of fully reach its onset of action. So you give the Lantus, you let the drip run for about 2 more hours, and then you can go ahead and stop it after that. Okay, so okay, and if you're going to also determine the dose of that subcutaneous insulin, there are a couple ways to do it. You could do it based on weight, like we mentioned earlier with those calculations. What we'll often do, though, is use what their IV insulin drip rate is and kind of extrapolate from there. So one of the ADA's kind of recommended calculations for that, what you do is you look at the drip rate for the last 6 to 8 hours or the last several hours that have been keeping the patient's blood sugars stable and controlled, and then you extrapolate that rate over a 24-hour period. Then you can take 60 to 80% of that and use that as your total daily insulin dose. So if a patient is on 2 units an hour, then that would be 48 units over 24 hours, and 60 to 80% of that would be anywhere from 28 to 38 units total per day. And then you give half as a basal, so 14 to 19 of Lantus in that situation, and give the other half as bolus divided among the 3 meals, so 5 or 6 units of Humalog before the meals plus the sliding scale. And this is just a guideline. I mean, everyone, patients can be very different. There are a lot of nuances and, patients and their insulin sensitivities and levels of resistance, and they can be more resistant when they're acutely hyperglycemic and admitted in the hospital and then get better and very quickly in some cases. So, this is a general kind of guideline, but it's certainly not the end-all be-all as far as how dosing goes. But a good place to start, I suppose, and then kind of work your way from there. Okay, so that's pretty much all I have. I kept it pretty straightforward because this was the nuts and bolts. But if you guys have any questions, feel free to ask. And if not, that's okay too. Okay. Thank you very much. Yeah, no problem.
All right.
And you got it in the, yeah, you obviously got it in the email and everything like that.
Yeah, so I'll post it for all of them.
Okay.
So they can.
Thanks so much.
All right, thank you.
Yeah.
Thanks for coming.